Hey, my name is Chris. Today I'm going to be breaking down the ARRIVE trial. In the next minute, I'm going to just explain everything that happens, and then I'm going to go into it a little bit more in depth for the rest of the video. So this was a randomized prospective domestic study comparing women who either came in for spontaneous labor versus women who came in for planned inductions at full term. The main findings were broken down into perinatal as well as maternal. From the perinatal aspect, there were no differences in primary outcomes. One of the subgroup analyses did show that there was decreased need for respiratory support in those women who had been in the induction group for the perinatal outcome, but everything else was pretty much normal. Compared to maternal outcomes, they show that there was actually in the induction group decreased rate of cesarean section as well as decreased frequency of hypertensive disorders. Furthermore, they actually showed that patients who were in the induction group had lower pain scores compared to those that were in the spontaneous labor. But lastly, there was an increased time that patients would spend on the labor floor if they were being induced versus being spontaneously in labor. Hi, my name is Chris, and today we're going to be reviewing the ARRIVE trial. For the background of this paper and why we even did it, 1 in 4 patients in the United States is induced for labor, and that accounts for roughly 1.5 million patients who are nulliparous, not complicated singletons who are going to be going in delivering every single year. So that is our target population that this paper is referring to. The background of it was that there were some prospective studies, but there was no clear evidence that had a good randomized study that showed that induction versus spontaneous labor and which one was better. There were some studies that did actually show that spontaneous labor was superior than induction, but there was no actual nice big study, and that's what the ARRIVE trial was aiming to fill the gap in for. As I alluded to earlier, the study population, these patients were gathered between March 2014 and August 2017, so pretty recent to when this video is being pushed out right now. It was multi-centered, so it was all across the US. It was community and university centers, and it was also domestic, so all of it was in the US. There was no Finland and UK and stuff. The population was nulliparous, so they had not given birth after 20 weeks of gestation. That was their criteria. They were singleton, they were vertex, baby was head down at the time that they were screened in for the study, as well as, I guess, again, when they were randomized. Then the breakdowns for it, then this is all the basic NEGM paper. This is table 1, and what we can show from here is that, their BMI was usually under 30, then majority of them were aged under 35. So if this is your population of patients, then the ARRIVE trial is specifically geared toward your audience. For some other people, that might not be the case, and that's not necessarily the case for mine. We have the race breakdown right here. We have employment status. We have insurance status here, smoking, method of conception. All that's listed right here, and you can show that it's relatively equal between the two groups so that there will be no confounding variables. So the way the study design worked, asked a bunch of patients that were about to deliver between 34 and 38 and 6, and they screened them and they said, hey, are you singleton, are you vertex, are you low risk? And that was a huge thing. So this paper made sure that you were low risk, and there's a whole bunch of reasons why you would no longer be considered low risk, and I can list them right here, and you can read them while I explain the rest of the portion. But you were screened at this portion, you fit all the criteria, you were allowed to proceed forward, you'd be able to pass go, and then at 38 and 38 and 6 weeks of gestation, you were then randomized, and this was a 1-to-1 simple earn method, whether you were either going to go into the induction group or the spontaneous group. And you were reconfirmed, and you made sure that there was no medical indications at that time because you were screened maybe a few weeks prior, and your cervix was then checked either 72 hours before you were randomized or 24 hours after randomization, because you could go into spontaneous labor a little bit further on, and then you were just put in those two groups. If you were in the induction group, you were going to be induced between 39.0 and 39.4. And if you were in the spontaneous labor group, you were able to continue through until 40.5 for just a planned spontaneous labor, and you were not able to go past 42.2. We now went over the background, the study population, the design, the methods for the approach, and now it's just simply the results of the study. I'll show the first one, which there's 2 tables. The first one is the perinatal outcomes, which is their primary outcomes, and their secondary outcomes were maternal outcomes. So from the primary outcomes, we can see that there is no difference in perinatal effects between the patients who were induced versus patients in spontaneous labor. The other thing you can see right there kind of really is just that, needing respiratory support within 72 hours of life was actually decreased in patients who were induced. But the main thing, and that's like what the huge paper is, so it was non-inferior from a perinatal perspective, but it was superior from a maternal outcome because C-section rates actually decreased. And the C-section rate decreased from 22% in the patients who were spontaneously went in labor versus 18% in the patients who went in for induction. And that was a relative risk reduction of 0.84, which is like a pretty huge reduction. They also found that there was decrease in gestational hypertension, and the relative risk for that was 0.64. So, those are two main things that they ended up finding out in this study. And then I'm just going to go into a small caveat and place a little thing right here. There was a Tita et al. Sub-analysis of this paper in 2021. It's kind of huge, and they actually broke down C-section risk rates in maternal patients, comparing spontaneous and induction. And what they found is, patients who came in for spontaneous labor at 39 weeks had that 17% increased risk. But then if you look at actually patients who came in between 40 weeks, they saw that the increased risk was 22%. And if they came in for 41 to 42 weeks for spontaneous versus the patients who were induced between 39 and 39.4, the increased rate was 37.5%. So for the outcomes of this paper, so what we pretty much showed was that, inductions were non-inferior from a perinatal standpoint and actually superior when specifically looking at C-section rates and hypertensive disorders. In general, you need to induce 28 patients to avoid one cesarean section. The other things you need to think about, though, is that the healthcare expenditures, and there was a brief article that someone went out, and I'll post it in the link below, that was assessing it, and it's really hard to kind of really truly assess this, and the paper, actually the Arrive trial didn't actually go into it. But, the one thing is, they're actually on the labor and delivery unit for 6 hours longer. So, 14 hours was for patients who came in for spontaneous labor and 20 hours for the induction group. So they were in for 6 hours longer, but actually their postpartum stays were not as long. They had fewer cesarean sections, but they ended up actually going home faster than the patients who actually went into spontaneous labor. The other things that were important to note is that actually patients who get in for the induction group actually had fewer EM visits, fewer urgent care visits, fewer unanticipated OB visits, as well as OB triage visits. So from that perspective, there's actually decreased rate of expenditure. And then just to counter that, though, there was obviously more interventions and augmentations used in the induction group. So if they chose to use Cervidil, $400 down the drain versus Amisa, which is $4. But either way, you're spending more money in the induction category. But the paper overall said that there was no decreased risk or no decreased rate of money, but roughly like $87,000, I think is what they were saying if they grossly were assessing it. That being said, though, if you had to induce every single patient, those 1.6 million singleton nulliparous non-complicated patients, you would actually reduce the number of C-sections each year by over 87,000, which is like an insane number of C-sections that you can reduce it by. And the last thing I want to talk about, and I know this is a different paper, but for patients over 35, the Arrive trial really doesn't address that population because most of the population was like 23, 24 years of age was median for either group. So for patients above 35, there's actually a Walker et al. Paper in 2016 that came out, and I'll link the link below. This was UK based, so it's not domestic like the Arrive trial. But what they were showing was that in patients grade 35, they pre-stratified them, accordingly. But what they found was that there was no difference in cesarean section rates between patients who went in for induction versus spontaneous labor. But in that study, you have to remember that there was like 600 patients, 619 to be exact, I think, in that UK study, the Walker et al. Paper, whereas in the Arrive trial, there was 6,000 patients. So, it's still reassuring to think that we can extrapolate the Arrive data to the AMA category above the age of 35, given the Walker et al. Data that came out in 2016. I guess we're still waiting for a new paper to really address that, or an Arrive trial for a more appropriate population. I think where we're showing that our patients are coming in for deliveries later on in life. But anyways, that was the main breakdown of the ARRIVE trial. I hope it helped. I hope it clarified some of the stuff, and I hope it gave good understanding to why it can be beneficial for maternal outcomes to offer this to patients. But at the end of it all, it really is maternal decision. So it's providing the information to the patients to understand that they are making an informed decision on how they want to proceed with birthday parties. Thanks for tuning in, and I'll talk to you guys soon.